organizing committee for giving me the opportunity to talk about optimizing medical therapy in different forms of congenital adrenal hyperplasia today. So adrenal steroidogenesis starts with cholesterol, and uptake of cholesterol is mediated by star protein, and it is converted to pregnenolone by the action of CYP11A1 or side chain cleavage enzyme, and by the aid of various steroidogenic enzymes and some cofactor proteins in adrenal cortex, they produce main stress hormone, main glucocorticoid cortisol, and main mineralocorticoid aldosterone, and sex steroids. And the deficiency of these various...
Dr. Tulay, your presentation we're not able to see.
Excuse me. Shall I reshare?
Yes, please. Yes, please. Yeah.
Okay, now can you see it?
Yes, 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 starting.
And
yes.
Can you hear my voice as
yes,
well?
Yes, clearly. Yes, clearly.
Okay, great. So the deficiency of these adrenal enzymes or cofactors result in congenital adrenal hyperplasia or CAH, which is characterized by constellation of signs and symptoms related to inherited inability to synthesize cortisol. And these conditions may be accompanied by the deficiency or excess of mineralocorticoids or sex steroids or their precursors. All CAH cases are inherited in autosomal recessive trait, and most commonly in about 90% of cases are due to 21-hydroxylase deficiency. Rare forms include 11-beta-hydroxylase, 3-beta-HSD, 17-hydroxylase, P450 oxidoreductase or POR deficiencies, side chain cleavage or CYP11A1 deficiency or STAR deficiencies. Most of these CAH has a severe classic or a milder non-classic forms. I will briefly mention about these forms. The most common one was 21-hydroxylase deficiency, as already mentioned. This enzyme is involved in the biosynthesis of mineralocorticoids and cortisol. And if it is deficient, the upstream precursors, especially progesterone and 17-hydroxyprogesterone levels, are elevated. This high 17-OHP is converted to 21-deoxycortisol, which is a recently described major biomarker of diagnosis of the condition, together with 17-OHP. And these accumulated upstream precursors are diverted to canonical androgen biosynthesis pathway, which include DHEA, androstenedione, and testosterone. Not only canonical or classical androgen biosynthesis pathway, but also accumulated progesterone and 17-OHP are diverted to alternative and backdoor pathway, androgen production pathway, to produce DHT by the action of 5-alpha reductase 1, 3-alpha reductase, CYP17, and HSD17B3 enzymes. And we have canonical androgen pathway, backdoor androgen pathway, and lastly, we have 11-oxoandrogen pathway because of elevated androstenedione and testosterone are converted to 11-hydroxy forms of metabolites by the action of CYP11B1 or 11-beta-hydroxylase. And they are also converted to their keto forms. And these are potent androgens like testosterone and dihydrotestosterone, and they contribute to hyperandrogenism in these 21-hydroxylase deficiency. And they are also used as important biomarkers of diagnosis and monitoring. As we already discussed, 21-hydroxylase deficiency develops as a result of biallelic mutations of CYP21 gene, And these 12 mutations here are responsible for 75% of the cases. If enzyme deficiency is severe, we see salt wasting and simple virilizing forms. If enzyme activity is more than 20%, we see non-classic forms. Genotype-phenotype relation is good in salt wasting and non-classical forms. However, this relation is poor in some cases with simple virilizing 21 hydroxylase deficiency. So although being an autosomal recessive disease, 21 hydroxylase deficiency is relatively common because and carrier rate is high because of high variability of genomic location of CYP21, which is located in HLA class 3 region, a very variable part of the genome in chromosome 6. And as already discussed, the main presentation is classic form, which is seen in 1 in 10,000 to 15,000, and patients present with salt wasting crisis, and we see XXDSD and pre- and postnatal virilization in both males and females. As you see, two of our patients, this is a female, severely virilized, hyperpigmented, and with ambiguous genitalia. This is a XY patient with severely virilized, with a macrogenitalia, macropenis, and hyperpigmentation. In non-classic form, it is much common, 1 in 200, but most of them may be asymptomatic. So they present at later ages with premature adrenarche, and females may come to attention with menstrual irregularities, hirsutism, acne, and infertility. You see these siblings, boys, at 5 and 6 years old with premature adrenarche and virilization. And this 4-year girl has acne, as you see here, premature adrenarche and clitoromegaly, and this young lady has hirsutism and acne. In biochemistry, in classical form, you see hyponatremia, hyperkalemia, elevated renin and ACTH, low cortisol. However, in non-classic case, electrolytes, ACTH, renin, and cortisol are generally normal. However, in both forms, you see elevated 17-OHP, DHEAS, androstenedione, testosterone, and very importantly and significantly, elevated 21-deoxycortisol and elevated 11-oxyandrogens, which differentiate this condition from the rest of virilizing CAH conditions. So in summary, we see XXDSD, adrenal steroidogenesis is impaired, glucocorticoids and mineralocorticoids are deficient, and there is androgen excess. So our treatment should target these problems. We treat with hydrocortisone at supraphysiological doses like 10 to 15 milligrams meter square day in 3 to 4 divided doses. And our aim is to replace glucocorticoid deficiency and suppress androgen excess. But we don't try to normalize ACTH or 17-OHP. We just try to normalize androstenedione and testosterone, because normal 17-OHP levels just indicate an overtreatment. So we aim to keep it around 3 to 12 nanograms per milliliter. Because we give supraphysiological doses of hydrocortisone, we monitor linear growth, weight gain, puberty, and bone age, especially after 2 years of age, in each 2 years or 3 years. For mineralocorticoid deficiency, we treat in salt wasting forms with fludrocortisone at a dose of 0.1 to 0.2 milligrams per day in 1 or 2 divided doses. And we monitor mineralocorticoid treatment with measurement of electrolytes and renin. If we undertreat the patient, then bone age will be advanced and we can see precocious puberty. In such cases, we consider GnRH analogs adding to the treatment. Also, in adolescents and adult women with hyperandrogenism, we can consider oral contraceptives and anti-androgens like spironolactone, flutamide, and finasteride adding to the treatment. We can see adrenal rest tumors in boys even at the age of 6 months of 6 months old. So we should monitor for adrenal rest by physical examination and ultrasound in each clinical examination, and ultrasound in each 2 to 3 years. And we should discuss about surgical correction of atypical genitalia in females. 11-beta hydroxylase deficiency. 11-beta hydroxylase is less common, and it is involved in the production of mineralocorticoids and cortisol. So there is an accumulation of 11-deoxycorticosterone, DOC, which activates mineralocorticoid receptor and cause hypertension. And 11-deoxycortisol is elevated. These two metabolites are diagnostic biomarkers of the disease, main diagnostic biomarkers. But because 17-OHP is at the upstream, there is mild elevation of 17-OHP, and a virilized girl may be misdiagnosed as 21-hydroxylase because of this mild elevation, and may be diagnosed during the neonatal CAH screening tests. This 17-hydroxyprogesterone and upstream precursors are diverted to canonical androgen biosynthesis pathway. So we see significantly elevated androstenedione, maybe the most significant one, and high testosterone. But these androgens cannot convert it to 11-oxy metabolites because of the enzyme deficiency. So 11-oxo metabolites are low. And 17-hydroxyprogesterone triggers the activation of alternative pathway and elevated DHT in the patients. So I will briefly mention the classical 11-beta hydroxylase and non-classical 11-beta hydroxylase deficiencies. Totally, 11-beta hydroxylase deficiency is around 5 to 10% of all CAH cases, and typically patients present with hypertension, XX-DSD, pre- and postnatal virilization in both males and females, and in advanced time, they can present with premature puberty, advanced bone age. Most severe advanced bone age is seen in 11-beta hydroxylase deficiency, more severe than 21-hydroxylase deficiency. More severe hyperandrogenism is seen in 11-beta hydroxylase deficiency, and most impaired final height is 11-beta hydroxy deficiency, around -2 SDS. Because I will mention about the biochemical picture. Sodium is normal to high, potassium is low, there is hypokalemic alkalosis and suppressed renin activity because of excessive mineralocorticoids. ACTH is high, cortisol is low, and 11-deoxycortisol, DOC, and androstenedione is very high. So androstenedione is highest in 11-beta hydroxylase relative to other virilizing CAH, and this androstenedione is aromatized to estradiol, and this contributes to advanced bone age and impaired final height, and also development of gynecomastia in male patients. And in contrast to 21-hydroxylase deficiency, these cases have low 11-oxoandrogens and low 21-deoxycortisol. This is a discrimination between 21-hydroxylase deficiency. These two cases is from our cohort. This a female patient with severe virilization and hyperpigmentation, and this boy is at 2 years old, and you see the masculine habitus and hyperpigmentation. So you see gynecomastia because of aromatization of androstenedione possibly, and virilization of genitalia and macrogenitalia here. Non-classic 11-beta hydroxylase deficiency is much rarer, around 10% of all 11-beta hydroxylase cases. In these patients, enzyme activity is maintained at 5 to 10%. These patients don't have hypertension, or hypertension is very rare. We don't see XX-DSD. Female genitalia is normal at birth, but at later ages, both males and females may present with premature puberty. height is impaired, in adult height is impaired, and there is a significant advanced bone age. Final adult height is around -1 SDS. In laboratory findings, electrolytes are normal. ACTH is normal or mildly high. Cortisol response to ACTH stimulation is normal. But the diagnostic precursors, 11-deoxycortisol, DOC, and androstenedione is elevated. You can see this graph that these upper ones are classical cases. These triangles are non-classical cases. When you look at 11-deoxycortisol per cortisol and DOC per cortisol ratios, there is a clear demarcation between classical and non-classical ones compared to healthy controls in both diagnostic biomarkers. So there is a good clinical and biochemical correlation with genotype in these 11-beta hydroxylase deficient patients. And bone age is advanced in both classic and non-classical case, but more significant in classical patients. So we see XX-DSD and adrenal steroidogenesis is impaired, glucocorticoids are deficient, and there are excessive mineralocorticoids and sex steroids. So we treat patients with supraphysiological hydrocortisone, and we try to normalize if we can. It is really difficult to manage. We try to normalize androstenedione and testosterone, and if there is hypertension in classical cases, we consider mineralocorticoid receptor antagonists like spironolactone and calcium channel blockers. And if there is precocious puberty, we consider GnRH analogs. Because adult height is impaired, we should sometimes we consider growth hormone aromatase inhibitors for selected cases. And additionally, in hyperandrogenic females and adolescents, we can consider oral contraceptives and anti-androgens. Adrenal rest tumors can also be seen in 11-beta hydroxylase cases, so we monitor for this. And we discuss about surgical correction of atypical genitalia in females in classical form. So 3-beta HSD deficiency is much rarer, and it is involved in the conversion of delta-5 steroids to delta-4 steroids. So all adrenal and gonadal steroidogenesis is impaired. So we have elevated delta-5 steroids, including pregnenolone, 17-hydroxypregnenolone, and DHEA. These are diagnostic precursors. However, elevated 17-hydroxyprogesterone are a little converted to 17-OHP by the action of 3-beta HSD type 1 isoenzyme. And this mild elevation of 17-OHP may cause a misdiagnosis of mildly virilized female as 21-hydroxylase deficiency, and these patients can be diagnosed during the neonatal CAH screening tests. This mildly elevated 17-OHP can trigger alternative pathway to produce DHD. And 3-beta HSD is less than 1% of all CAH cases. And there are two clinical forms of 3-beta HSD deficiency: classical salt wasting and classical non-salt wasting 3-beta HSD deficiency. In salt wasting form, the enzyme activity is less than 1%. Patients present with salt wasting crisis. In XY, DSD is a must. In all XY patients, you see DSD. But in XX or female patients, you cannot see DSD, or if you see, there is a mild virilization at birth. So I will come to that point. But you see premature adrenarche at later ages in both females and males, and hyperandrogenism in adolescent and adult females. So in our big cohort of 35 patients with 3-beta HSD deficiency, all XY cases had DSD. You see here hyperpigmentation and ambiguous genitalia. And only one female patient in our cohort has mild virilization, mild clitoromegaly, and this patient has a severe homozygous frame shift mutation in TRPV HSD gene. So really, DSD is rare in TRPV HSD. So in laboratory findings, patients have high ACTH and renin, hyponatremia, hyperkalemia, cortisol is low, and delta-5 precursors are elevated. In contrast to 21 hydroxylase deficiency, these patients have low 11-oxyandrogens and low 21-deoxycortisol. As I said, there is another non-salt wasting classical 3-beta HSD form. In these cases, enzyme activity is around 5 to 10%, and as a result, they have a spared mineralocorticoid function. So although they have low sodium, their potassium levels and plasma renin activity is quite normal. And however, they have high ACTH and low cortisol, and they have elevated delta-5 steroid precursors. So in XY patients, we see DSD, and we see premature adrenarche at later ages and hyperandrogenism in adolescent and adult females. As far as I know, and we screen so many patients for non-classic 3-beta HSD with normal cortisol levels. But however, I don't think there is a non-classic case, 3-beta HSD case is existing, which is molecular proof, which is proven molecular way. If it exists, then it should be really extremely rare. So we see both XX and XY DSD, both adrenal and gonadal steroidogenesis is impaired. All steroid hormones are deficient. So in treatment, we give hydrocortisone at high doses to normalize ACTH and DHEAS. And in salt wasting form, we replace with mineralocorticoids. And we consider sex hormone treatment for patients who fail to progress through puberty. And for women who show hyperandrogenism symptoms, we can add oral contraceptives and anti-androgens to the treatment. These patients, male patients, may also have adrenal rest tumor, and we monitor these patients. And we discuss about surgical correction of atypical genitalia, especially in male patients with 3-beta HSD deficiency. CYP17 deficiency is another rare form, and it has two activity. Hydroxylase activity is involved in the biosynthesis of cortisol, and lyase activity is involved in the synthesis of sex steroids in both adrenal glands and gonads. So in deficiency states, as you see here, progesterone, DOC, and corticosterone is elevated, and this corticosterone excess compensates for cortisol deficiency. So the patients don't show clinical signs and symptoms of cortisol deficiency. Excess DOC causes low renin hypertension. Because gonadal steroidogenesis is impaired, both males and females have hypergonadotropic hypogonadism. Female patients are normal at birth, but they don't undergo adrenarche or puberty. XY patients have severely undervirilized external genitalia, and more commonly they present with female phenotype. Because sex steroids are not produced at all, the bone mineral density of the patients are low even before the glucocorticoid therapy is initiated. In biochemistry, we see normal to high sodium, low potassium, and suppressed renin because of excessive mineralocorticoid activity, high DOC, high corticosterone and progesterone, and low 17-hydroxylated steroids, and low adrenal and gonadal sex steroids. Because there is no clinical sign of cortisol deficiency, these patients come to attention at pubertal ages because of pubertal problems. However, if there is a severe symptomatic hypertension or if there is a partial deficiency of CYP17 in a male patient, it may cause XY-DSD, then they can be diagnosed at earlier ages. So in CYP17, both adrenal and gonadal steroidogenesis are affected. We see XY-DSD, and deficient hormones are glucocorticoids and sex steroids, and mineralocorticoids are excessive. So we dose to suppress mineralocorticoids, and if there is hypertension, we add mineralocorticoid receptor antagonist and calcium channel blockers, and we monitor with ABPM in each 2 to 3 years. We can consider gonadectomy in severe XY cases because they are generally raised as females and they don't have any brain virilization. And then we can start age and gender appropriate sex steroid replacement in puberty.
Dr. Tulay, sorry, I think your net was not working for a second and your screen is gone.
Okay.
Yes, we can't see the slides.
Okay, sorry. I can
last one slide. Last one slide.
Okay, I can reshare.
Yes, thank you.
Okay. Okay.
Just the last one.
Okay. So yeah. Okay. For hypertension, we should add mineralocorticoid receptor antagonists or calcium channel blockers, and we can consider gonadectomy in severe XY cases because they don't have any brain virilization and they are generally raised as females. And in puberty, we can plan age and gender appropriate sex steroid replacement. P450 oxidoreductase or POR deficiency. POR is an electron donor of various microsomal P450 enzymes, including 21 hydroxylase, 17 hydroxyp17, and aromatase. So in POR deficiency, you see more or less deficient CYP17 and deficient 21 hydroxylase and aromatase findings. So the symptoms and hormonal findings are greatly variable depending on the deficient enzyme and extent of deficiency. Because POR also gives electrons to CYP26B1, there is also a skeletal phenotype called Antley-Bixler syndrome. In this phenotype, you see craniosynostosis, radioulnar and radiohumeral synostosis, mid-phase hypoplasia. It causes DST in both males and females, and because aromatase deficiency, mothers in pregnancy may be virilized. So these are some of our POR patients. You see skeletal defects and you see synostosis in humerus and radius and ulna and femoral bowing here. And they have a very typical phase, as you see here, midfacial hypoplasia, and especially the noses are very characteristic and they are very significant and with fleshy tips you see here. If you see a couple of them, then you can diagnose them by looking at their nose really. So in laboratory findings, you see normal or near normal cortisol levels, but they respond poorly to ACTH. So even if you see the normal basal cortisol levels, ACTH test is recommended to show cortisol deficiency. ACTH is high, DOC, 17-OHP and progesterone is high, and androstenedione and adrenal androgens are low. So as I said, both adrenal and gonadal steroidogenesis is impaired, and there is DST in both males and females. Glucocorticoids and sex steroids are deficient, and there is excess of mineralocorticoid precursors. So we use high-dose hydrocortisone to suppress ACTH and mineralocorticoid excess. And if there is hypertension, we add treatment as a mineralocorticoid receptor antagonist, and also sex hormone replacement at pubertal ages. Lastly, I will mention together about side chain cleavage enzyme deficiency and star deficiencies, because these two conditions are cause quite similar clinical and biochemical condition in clinical and biochemical similarity. So they both affect all, biosynthesis of all type of steroids, and they both have classical and non-classical forms. This is interesting because we know that in severe classical star deficiencies and side chain cleavage deficiencies is incompatible with life. But if they are alive, we can see, I will give an example of side chain cleavage deficiency, a severe case, a classical case. This patient presented at 10 hours of life with hyperpigmentation, severe hypoglycemia and hypotension and salt wasting at 10 hours of life. And genitalia was female, but the karyotype was XY. And patient had a severe homozygous mutation in CYP11A1, which has a null activity. So we have treated this patient with hydrocortisone, fludrocortisone, and salt replacement. And in these patients, because they don't have any gonadal or adrenal sex androgens, we can consider orchiectomy in these XY patients. And then we can also consider age and gender appropriate sex steroid replacement in puberty. In both star and CYP11A1 cases, you can also see a non-classical condition. This is a non-classic CYP11A1 deficiency. The patient presented at 4 years of age with salt wasting. He had micropenis and bilateral cryptorchidism. And we found a homozygous CYP11A1 mutation, which has 30% of activity. So this patient is treated with hydrocortisone and fludrocortisone, and possibly he will need sex hormone replacement at pubertal age. So in both conditions, we can only discriminate these two conditions by genetic testing, and sometimes with imaging, because we know that in side chain cleavage you see atrophic glands, and in star deficiency adrenal glands are grossly enlarged, but not always. So this is not a rule. But if you see grossly enlarged adrenal, you can say this may be a star deficiency. In both conditions, all steroid hormones are deficient, and they are unresponsive to ACTH and human chorionic gonadotropin. So this is an important point. We treat these patients with hydrocortisone, but at replacement doses, like 6 to 8 milligrams meter square per day. Not a suppressive dose is used, because we don't need to suppress any mineralocorticoids or androgens. Because they have severe salt wasting, we need salt supplementation in newborn and early infancy, in addition to mineralocorticoids. And XY, in severe XY patients, we can consider orchiectomy, and then age and gender appropriate sex hormone replacement at puberty. So as already discussed, fine-tuning in glucocorticoid treatment in virilizing forms of CAH is important, because if we undertreat patients, we can see adrenal crisis, virilization because of androgen excess, advanced bone age, and short adult height. If we overtreat the patient, then we impair growth, and we can see osteoporosis, poor bone health, poor metabolic outcomes, obesity, insulin resistance, type 2 diabetes, hyperlipidemia, poor cardiovascular outcomes. And in both overtreatment and undertreatment, fertility and reproduction may be impaired. So we prefer hydrocortisone in childhood. Long-acting glucocorticoids like prednisolone, methylprednisolone, and dexamethasone, they have longer half-lives, but they have significant growth restricting potential. So we prefer this long-acting glucocorticoids only after adult height is attained, or in adolescent females for regulation of menstrual cycles, or for fertility induction, or if patient is adherence to the treatment is poor, we can choose these options. Dexamethasone, we can use dexamethasone for fertility induction or adrenal rest tumor treatments. And we should remember that dexamethasone may cross the placenta and suppress the adrenal functions of fetus. We have talked about the importance of circadian and diurnal secretion of cortisol. In fine-tuning of glucocorticoid treatment, we should mimic this physiological cortisol secretion. So there are some novel treatment strategies in virilizing form of CAH. For example, modified release preparations like Plenedran and Chronocort. There are some phase 3 studies are ongoing. For example, Plenedran may provide an excellent early morning cortisol peak, but it cannot suppress well the morning ACTH and high androgens early in the morning. However, Chronocort, when it is given at midnight at a single dose, you can provide a suppression in early morning ACTH and androgen suppression. But in the morning, you need to give another low dose of Chronocort to provide a daytime cortisol coverage. So you see the area under curve cortisol is high, so you may end up with iatrogenic Cushing. Hydrocortisone pump is an excellent option mimicking circadian rhythm, but it is costly, not practical, and you need to educate patients, and there are some technical problems. So they are not commonly used in the pediatric treatment. So there are some other trials for other drugs. For example, CYP17 inhibitor abiraterone acetate has been used in some adult CAH women to suppress hyperandrogenism. It is safe and it didn't cause any hypokalemia or hypertension, and it is used in addition to hydrocortisone. Again, corticotropin-releasing hormone antagonists block ACTH secretion, so you need to add hydrocortisone, you block and replace, and it is safe and effective to control hyperandrogenism in adult CAH patients, but they are not used in pediatric patients. There are some additional studies about MC2R antagonists, ACTH antibodies, CYP11A1 antibodies, and 3-beta-HSD inhibitors for treatment of virilizing CAH. And but however, they are not used in pediatric practice at the moment. So these patients cannot increase their cortisol in stress conditions. So they need to increase their drugs in conditions of stress, and they need to have emergency condition cards with with themselves. This card should include information about their disease, their medications, contact informations of their doctors and their family. And in very minor stress conditions like exercise, emotional stress, fever lower than 38.5 degrees, routine vaccinations in mild febrile infections, we don't need to adjust hydrocortisone dose. But in minor stress, like small surgeries less than 1 hour in local anesthesia, colonoscopy, endoscopy, mild febrile illness, mild nausea, vomiting, mild diarrhea, and single tooth extraction, we double or triple the oral hydrocortisone dose. to 25 to 50 milligrams per meter square oral or intravenous hydrocortisone or bioequivalent, but we don't need to taper the dose to the maintenance when the stress subsides. However, in moderate stress, like pneumonia, fractures, and multiple tooth extractions, we have to give systemic hydrocortisone at a dose of 50 to 75 milligrams per meter square or equivalent as a bolus, and we continue with the same doses as continuous infusion or 4 divided doses, and then taper to the baseline over 1 or 2 days when the stress subsides. In major stress like septic shock, severe trauma, burns, severe infections, multiple fractures, major surgery, and pancreatitis, we have to give intravenous hydrocortisone at 100 milligrams per meter square or equivalent as a bolus, and we continue at the same dose as continuous infusion or 4 divided doses, and taper this dose to baseline over 1 or 2 days when the stress subsides. Lastly, in acute adrenal crisis, which means severe cardiovascular decompensation in addition to findings of cortisol deficiency. So there are 3 important points here. As in the major stress, we treat these patients like 100 milligrams per meter square intravenous hydrocortisone source start, and then we maintain this dose, same dose in continuous infusion or in 4 divided doses, and taper the dose over 1 or 2 days. So because of severe dehydration and hypotension, we should give intravenous fluids, normal saline in 10% dextrose to avoid hypoglycemia. We start with a bolus, then depending on the severity of dehydration and hypotension, we maintain with these fluids, and we treat patients for underlying pathologies and most commonly antibiotics for the infections. These are all I would say, and I would like to thank you for your attention.
Thank you very much, Dr. Tulay, for an excellent presentation covering almost all the varieties of CAH. If we can quickly take a couple of questions so as not to disappoint the askers. Shall I read them out, or I'll quickly read them out?
Yes, please.
Yes, yeah. So how do you decide whether to give 3 or 4 doses of hydrocortisone? Is there any condition where we need to give 4 doses?
Both ways are okay for us. We prefer continuous infusion. It doesn't affect the result.
Okay, and an extended question. In certain older children, we do see the requirement for hydrocortisone comes down pretty significantly, even with a smaller dose, 17 OHP stays.
Could you please repeat it?
Okay. In older children, the requirement for hydrocortisone comes down. Shaila ma'am, if you can read it out, maybe my connection is poor.
Yeah. We have some 46XX21 hydroxylase salt wasting CAH on very low dose of hydrocortisone, as low as 5 to 6 milligram per meter square, and 17 OHP is persistently less than 1. So how many of your patients are on these low dose of hydrocortisone? Is there anything else to do?
Okay. So if they sometimes we see the young babies which have very suppressed 17 OHP levels at low doses of hydrocortisone. In such cases, you should be sure about your diagnosis first for 21 hydroxylase deficiency. And most importantly, we monitor the growth, not the hormones. If it is okay with 5 to 6 milligrams per meter square, we just decrease the dose or we just keep on that dose, we monitor the growth. Normal growth is the main outcome, I think.
If I can you hear me, Dr. Tulay?
Yes.
Yeah. Yeah. To extend that question, sometimes in confirmed 21 hydroxylase deficiency, we do see children developing hypertension, 95th to 99th centile, where we have to cut down on the mineralocorticoid doses. In couple of cases, we had to stop the mineralocorticoid. Is it the right way of going like that, or should we continue mineralocorticoid and treat with antihypertensive?
So you mean when you treat the patients with fludrocortisone, you see hypertension. So should I decrease the mineralocorticoids or should I add antihypertensives, you say, right? Is it the right question?
Yes.
Okay.
Yes.
So
yes.
First, we try to decrease the mineralocorticoid dose. And we also monitor electrolytes. If there is hypokalemia, especially, you need to decrease the dose. I haven't seen any case with low mineralocorticoid treatment and hypertension. Only this is an extreme condition, but a complete deletion of CYP21 gene may cause hypertension. I really wonder the mutation of that patient, because I have a couple of patients with complete deletion of CYP21 gene, and these patients have hypertension even at low doses of fludrocortisone treatment. I would be pleased if he or she can share the mutation of this patient. So I haven't seen a classical 21 hydroxylase deficiency treated with fludrocortisone and antihypertensives, except these a couple of patients with complete deletion of the gene.
Thank you. Sure. The mutation, this is CYP21A2 mutation, but not sure about whether it is complete deletion or not. I have to go back on that. Thank you.
So Dr. Ashu wants to know how frequently do you monitor testosterone and androstenedione in 21 hydroxylase deficiency CAH, and what levels do you want to keep them at?
Okay. So in the first year of life, we monitor patients in each 3 months. And after 1 or 2 years, we monitor patients around 4 to 6 months. And we try to normalize androstenedione and testosterone levels just in normal limits. But we don't normalize 17-OHP and ACTH. This is just an over-treatment.
Is it necessary to do ACTH stimulated 17-hydroxyprogesterone in follicular phase of menstrual cycle?
Yeah, this is important, and thank you for this question. In luteal phases, especially in adolescents and adults, you can see high 17-OHP levels up to 3.4 to 4 nanograms per milliliter. So it is important to take 17-OHP at early follicular phase and early in the morning.
Thank you. Do you do 2 hours post hydrocortisone serum cortisol for knowing adequacy of replacement? What levels do you keep? This is our pediatric and adult friend.
No, we don't use serum cortisol for monitoring, but we have a steroid profile measured by LCMS, and we really trust this steroid profile, and really we don't make ACTH stimulation tests in patients with suspicion of CAH. In basal conditions with LCMS steroid profile is very diagnostic. This is my experience. But we don't monitor patients with serum cortisol levels.
His question was not after ACTH stim, it's just monitoring time to see the adequacy of replacement. Do you do 2-hour post treatment?
Sorry, I couldn't understand the question.
Yeah, I think you answered, Dr. Tulay said you will not be monitoring serum cortisol
No, we don't.
for adequacy
We
of the
don't
treatment.
monitor cortisol for treatment. No.
Because in adult practice, in adults, they normally do 2 hours, 4 hours, 6 hours pre and post treatment. So that was the reason. But we don't do actually in pediatric case.
Also,
yes.
we don't use measurement of serum cortisol to diagnose a Cushing disease as well. So if we suspect about Cushing disease, we just make dexamethasone suppression test or diurnal cortisol measurements. We don't measure random cortisol to diagnose any endogenous hypercortisolism as well.
Sirisha, you can ask the next one. It's your question.
Yeah.
I think you have already asked.
I think we have almost completed. In salt wasting, does fludrocortisone vary during transition from adolescent to adulthood? Requirement for fludrocortisone is what, as I see. Does the requirement for fludrocortisone vary from adolescence to adulthood?
Yeah. Normally, even after adolescence, even sometimes they stop fludrocortisone treatment, but they eat salty, so they can provide their need of salt directly from salt. So we don't prefer this. We always suggest them to continue their fludrocortisone treatment in adulthood because it also decreases the need of hydrocortisone. So we suggest say that they need to go on with their fludrocortisone treatment.
Sure. Is there any guideline on time of measurement of 17-OHP? And if on prednisolone, how much time gap should be there between the tablet intake and measurement of 17-OHP?
So we normally they both CAH patients and Cushing syndromes lost their diurnal rhythm. So it doesn't matter if you measure 17-OHP in the morning or in the afternoon. So because they don't have a circadian rhythm. So, but we prefer to see 17-OHP values as a, as a standard in the morning and before the morning dose of hydrocortisone. There is no guideline, but we prefer this way.
Yeah, an extension to the previous question asked. In the case of PCOS, we are supposed to measure 17-OHP in the follicular phase, but what if the child presents with irregular cycles?
If there is irregular cycles, there is no possibility you just measure at any time. But early in the morning, at least.
Yes. Yes.
But
if I may,
excuse me, I would really suggest in these cases, to measure, if possible, 21-deoxycortisol. This is really, in my experience, in carrier 21 hydroxylase carriers, you see a mildly elevated 17-OHP. But in carriers, you don't see high 21-deoxycortisol. So 21-deoxycortisol is really specific, just specific for 21-hydroxylase deficiency and a certain extent to POR deficiency, because in POR deficiency, you can also see 21-hydroxylase deficiency. So only in POR, but POR has a different clinical presentation. So only in POR and 21-hydroxylase deficiency, not in any other CAH.
Yeah, I think that answers that. Finally, before closing, if I may ask, these two conditions in 3-beta HST deficiency, what are the I think you mentioned already, if you can just mention again. The biochemical monitoring. How do we monitor?
So
we
for 3-beta HSD deficiency, because we have the facility of LCMS, we monitor with 7 delta-5 steroids, 17-hydroxypregnenolone, pregnenolone, and DHEAS. But if you don't have this facility, you can monitor with DHEAS, and you need to normalize ACTH and DHEAS.
Yes. Thank you so much, Dr. Tulay. Dr. Shaila.
I am very happy.
Thank you very much, Dr.
I am very happy to be with you today.
Answer questions. Any more questions we can ask?
And yeah, I think we have covered most of the questions in the chat box.
I think there's one more is how frequently should we monitor renin in CAH patients only on glucocorticoid replacement?
Okay, great. So we monitor renin in a year because we don't have a facility to measure renin. This is the truth.
Facility.
But even in the guidelines, it is enough to monitor renin once a year. But you should need to monitor electrolytes in each clinical visit and blood pressure, which is more important. Even if you can measure aldosterone and renin, there are some technical issues and they can mislead you. So blood pressure and electrolytes, I think it's more reliable. But if you have this facility, we can measure renin in each year.
Can we follow the same kind of clinical monitoring for 11 alpha hydroxylase when we don't have facility for monitoring 11 DOCA? For 11 alpha hydroxylase deficiency, can we do the same clinical? Can we just, is it okay, good enough to continue clinical monitoring alone?
Okay.
With blood pressure and lights and
salt?
Yeah. Even in CYP17 deficiency, we monitor electrolytes and blood pressure, and it should be okay.
So it has been a age-old tradition, or everybody is continuing. We don't concentrate on measurement of testosterone or androstenedione. We still stick to 17-OHP. I think all over India, most of us are all sticking to 17-OHP in the monitoring, other than the growth monitoring. This is biochemical.
Yeah. This is the most important message I would give for 21 hydroxylase deficiency. I never stick to 17-OHP at all, really. Androgens a certain extent, but mainly growth and normal growth for puberty and age.
Okay, I think we will change our practice after your lecture.
Couldn't agree more, Dr. Tulay. Clinical response and monitoring is number one monitoring. Biochemistry comes later. And we do see when we do occasionally testosterone and androstenedione for follow-up, we do see them well suppressed even when the 17-OHP is high. So we learn that it's okay to continue the doses.
I think so. Yeah.